Good afternoon to everyone. We actually have two panelists with us today, both Felipe Palacios and Dr. Vega. I'll introduce them in a moment. But actually, before we do anything else, I'd like to get everyone to stand up. One, because it's 3 o'clock, there may not have been enough coffee, you know. This is going to be about an hour, right? And I want you to turn to look towards that table over there. The one in that back corner. The one with the students from Academia de Perpetuo Socorro, right? You heard about, these are high school students. High school students working on overutilizers. And I want you to think about something for a moment. The healthcare system that we will deliver by changing and getting out of the crisis that we're in is the one that will affect them the most. It'll be a big part of their lives, and they're just starting off their lives. They're 9th and 10th graders, and 2 to 3 years, they'll all be graduating high school, and they'll be going on to university. And whatever healthcare system we have here in Puerto Rico, in the United States, and around the world, is the one that they're going to live with for the rest of their lives, right? Integrating young people like them and having young people like them be curious enough, interested enough, willing to dedicate time to something as complex. And if you're a high school student, when you first hear your teacher say, we're going to work on overutilizers, I'm sure tons of students just jump up and down in joy and say, wow, that sounds like the most fascinating thing I've ever heard. Thank you so much. God, could I have some extra calculus now? Right? So I think we should give a round of applause to young people who are willing to take on very complex things. All right? With that, let me kind of set up for you a little bit about what we're talking about now, right? There we go, right? Oh, I need to deal with something. I know what some of you are thinking. Now, when you saw, there was someone called Dana or Dana Montenegro speaking, I know many of you were wondering, wow, does he know that he has a girl's name in Puerto Rico? No se preocupe, es la culpa de mi mamá. I still receive phone calls from some of your companies, by the way, looking for La Señorita Dana Montenegro, right? I have lived with it my whole life. Do not worry. I am the right person to be here today. That is my name, right? También yo tengo español pateado. Yo tengo 16 años en Puerto Rico. Yo aprendí todo mi español en la escuela fina de idiomas que se llama Willy's Pinchos. So, with that in mind, we're going to continue in English, right? I mean, I could be flattering and say because, Dr. Brenner's here, we're going to continue in English. But really, I'm saving all of you from a long and lengthy discussion about cerveza, pique, pinchos, right? We're talking about something a little bit more sophisticated. I come from a company called Seriously Creative. This is my office, and it's actually interesting. Someone mentioned that creativity is just work at play. We take that very seriously at my office. Anyone over the age of about 35, maybe 40, understands what the Space Invaders on the wall are. The very young people in the room have no idea what that is, right? So we are a creativity, design thinking, and design strategy firm. We solve complex problems through a process called design thinking and human-centered design, which you just heard Dr. Brenner reference. And the best way to explain what we do is we take very complex problems for all kinds of industries. We work for consumer goods, service, financial institutions, and we understand that a lot of the problems that they face are very, very complex, very hard to understand. But they need to get through that complexity to find this evolving solution, a solution that makes money, delights consumers, is efficient. And what interests us about your industry is that you guys face really complex problems. Really, really deeply important complex problems, right? So all day you hear people talking about healthcare, healthcare systems, healthcare delivery, value in healthcare, right? I think what we'd like to present today and what our two panelists will be talking about is maybe we should be renaming this human care instead of healthcare. Because in fact, you've heard people from the early part of the morning talking about it's not about the nail. You've heard Dr. Brenner talk about it. You saw a video that humanized what healthcare is. And really the focus is that we need to start focusing on people and outcomes for people, right? And I bring you this quote. We keep trying to optimize the parts when we need to optimize the whole, from Michael Porter. How many of you know Michael Porter from Harvard Business, right? Harvard Business School. So many of you probably know him because you know that book, Redefining Healthcare. And part of what is going to be talked about today is we're talking about this. We're talking about that we need to redefine what value in healthcare is. And what he says is that value in healthcare is health outcomes, which are both clinical and the experience of the patient over the cost of delivering per patient, right? And that our theory is that by focusing on patients, on patient outcomes, instead of all the micro cost centers that we usually look at, we can lead to a more sustainable healthcare industry here in Puerto Rico, right? And one of the big things that he says is that in order to understand and deliver more value in healthcare, we need to go from a model where we tend to focus on the individual facets of our industry, right? Pharma, provider, payer, the policy makers. And we tend to look at this struggle between different ones of you here in the room, right? And instead start focusing, putting the patient at the center of all this relationship. Looking at what the outcomes for patients are. Designing services and user experiences around the patient. And you've heard about this dysfunction that patients experience, and that things that go beyond just simply coordinated care, right? And he says the way to understand the cost is to follow the patient. To follow the patient from before they're actually even a patient. To follow them as humans. And we follow them from before they have symptoms and first diagnosis and all these problems that come with these things. And understanding beyond the metrics, what blood pressure was, how much it costs to do this, how many medications are there on, and start understanding them from an emotional, a lifestyle point of view. What are their needs? What are their wants? What are they trying to accomplish? Where are their barriers, right? And what we're here to say is that there's tools to deal with exactly that in order to understand the patient better. And the one thing that you heard Dr. Brenner talk about was human-centric design. Another word for it's called design thinking. And design thinking is basically an iterative, human-centered approach to solving complex problems that delivers innovation. And companies like Apple, like P&G, and all these other people you see down here have been starting to adopt this. Understanding consumers or users at a deeper level in order to find insights. And it has several principles. Design thinking has these 6 principles. One says be radically collaborative. And you've heard some people talking about multifunctional teams already today. And design thinking says that we have to work across departments, roles, involve experts and non-experts in the process of designing up solutions. It also says we have to be human-centric by the nature of its name. It means understanding for empathy. It's data beyond the statistics. It's about asking, it's about observing, experiencing, in order to find the meaning behind patients' journeys and patients' experiences. It also says co-create with the user. We tend to want to design and create and develop and deploy things from our level of expertise. And what design thinking says is that we usually design and come up with better things when we're involving the patient, the end user, the provider in the conversation. And to involve them early and often in the process of developing new ways of servicing them, new ways of communicating them, new ways of helping them. Another is the idea of learning from outliers. Design thinking says you learn a lot by looking at the most extreme people. And today you are talking about the most extreme users. It says that people with extreme usages that go very outside the boundaries of what you normally see, those people are able to articulate for you better and deeper what the real problems are. 5th, it says experiment to learn. That we always have these big ideas and we invest a lot of money and a lot of time in them only to find out later that we missed something, that something didn't make sense and it doesn't work out. And design thinking says, well, if you don't know exactly if it's going to work or not, you experiment your way forward. You prototype, you test, you try little experiments, you check your assumptions, and through a very well-controlled process of quick little failures, you get to successes. And finally, it says make it visual. It says that for all the data that we present in bar graphs and pie charts, sometimes the best way to get everyone on the same page is to make it visual and to make it human and to show pictures of people and create visual diagrams. So These are the tool sets. And some of the things that design thinking asks people to do is to go out and ask people, to go spend time with overutilizers. It also says observe them. It says sometimes experience it for yourself. Go out and try to be a patient who has to go and get dialysis, and try to live their life in order to empathize with them, and then experiment along the way. And what it delivers is a lot of what was talked about today. It's improvements, but it's also innovation. And it's those disruptive innovations that Dr. Brenner was just talking about that we need to pursue. So this is the tool to get us there. And it's not just corporations doing this. It's not just the Coca-Colas and the Apple of the world. More people in healthcare are starting to use these kind of tools. The Mayo Clinic, Kaiser Permanente, the National Health Service of the United Kingdom, the Veterans Affairs Administration are starting to use design thinking in order to understand people better, in order to deliver more innovative solutions, right? And I'll give you a very quick little example. This is actually from the National Health Service in the United Kingdom. They had this fact. According to the National Audit Office, violence and aggression towards hospital staff cost the NHS at least £69 million. That's close to $100 million, right, a year in staff absent loss and productivity and additional security. And they could have sat around and they could have looked at a lot of data and they could come up with very complex ways to deal with this. They could have put more security in. But what they did is they sent their own people out to go understand what was going on. And they had interviews in simply 2 different emergency rooms in the London area. And through a series of a few weeks of interviews and observations and trying to understand what was going on, they found out the solutions were actually quite simple. They found out that people's frustrations and yelling and screaming was frustration. They didn't know where they were in the system. They felt like they were being abandoned. They felt like they'd been overlooked. And simply by giving them a little map to help them understand what would happen next, what was happening while you were waiting behind the scene, and by giving some very basic training to some of their frontline staff, it led to this. And 88% of patients felt that the guiding solution clarified the ambulatory and emergency process. 75% of patients said that it improved signage, reduced the frustrations during waiting line. 50% of reduced threats and aggressive body language. And they found that for every pound they invested, they got $3 worth of benefit in it. And they did that by going out and understanding people, using the tools of design thinking. So with that, I want to introduce our 2 panelists today. The first is Felipe Palacios. Felipe Palacios comes to us. He's the general manager of AbbVie. He actually has worked for AbbVie both in Latin America and the United States, and most recently, I believe, he's coming to us from Asia, where he's recently worked in Japan. He's now the general manager of AbbVie here in Puerto Rico. He's worked across the business in research and development, in licensing, in marketing, in executive management. He also comes to us with a PhD in biological sciences from the University of Notre Dame and an MBA from Tulane University. So please welcome Felipe Palacios. Thank you very much. And we also have Doctora Yvonne Vega Perez. She received her BA in biology at the University of Puerto Rico, Mayagüez. How many people, UP Mayagüez, colegio? All right, you're everywhere, right? She received a specialty in family practice at St. Joseph Mercy in a town that has become, unfortunately, very famous in the United States, Flint, Michigan. And later a focus on geriatrics at St. Louis Hospital in Michigan as well. She returned to practice medicine in Puerto Rico, and then now for the last 15 years, she's been working in healthcare management. And since 2007, she served as the Chief Medical Officer of Triple S Advantage. She also devotes much of her free time in working with nonprofit organizations who seek to improve the patient experience in Puerto Rico. So, we've been talking about a healthcare crisis in Puerto Rico and the need to innovate, the need to change. You've heard tons of speakers already kind of outline it for us. For each of you, explain how this crisis kind of touches your business, your industry. What is the problem we face?
Well, if I may, I will speak in Spanish because I don't want anything to be lost in translation. Voy a empezar con un caso que recientemente he estado involucrada. Hace como una semana y media, nosotros en S Advantage recibimos una orden judicial para investigar un caso en particular. Una paciente femenina de 85 años que básicamente nos estaban ordenando el tribunal que teníamos que coordinar el servicio del médico primario, así como el servicio de salud mental para una evaluación completa. Inmediatamente recibimos esa orden del tribunal, era alrededor de las 4:30 de la tarde, nos refería en la orden del tribunal que teníamos que buscar y teníamos que coordinar con varias agencias gubernamentales, tales como el Departamento de la Familia, el Departamento el Procurador del Veterano y otras agencias específicas. Obviamente ya a esa hora, a las 4:30 de la tarde, ninguna de estas agencias estaban disponibles, pero nosotros nos dimos a la tarea, activé nuestro departamento de manejo de casos, activamos nuestros diferentes departamentos para buscar dentro del sistema de información específicamente qué servicios nosotros habíamos adjudicado, ¿verdad? Habíamos pagado para esta paciente. Contrario a lo que hubiésemos esperado, nosotros no teníamos ni siquiera un solo encuentro de esta paciente, ni con su médico primario, ni en salas de emergencia, ni en ningún servicio en particular. No obstante, habíamos identificado sí a través del sistema de farmacia que sí había utilizado alguno que otro medicamento que no necesariamente eran medicamentos de mantenimiento, eran medicamentos de condiciones agudas. Entonces, pues básicamente nos extrañó muchísimo que una paciente de 85 años no tuviese servicios documentados al menos en el sistema. Inmediatamente contactamos o llamamos a su médico primario, no lo conseguimos y activamos nuestro programa de Gero Social. Gero Social es un programa que nosotros tenemos como parte del Departamento de Manejo Médico, donde básicamente tenemos trabajadoras sociales, entre ellas la líder es una gerontóloga con bastante experiencia en estos casos, ha sido parte de la asociación de hogares de cuidado prolongado, ha sido parte del Departamento de la Familia y es doctora en gerontología. Pues inmediatamente la llamamos porque a ella es a quien nosotros buscamos cuando tenemos este tipo de situación donde no tenemos cómo conseguir al paciente o cómo conseguir más información. Para hacer el cuento largo o corto, ¿verdad? Pues Minerva inmediatamente se dio a la tarea de buscar más información. Al otro día, temprano en la mañana, estaba visitando el Departamento de la Familia e identificando cuál era el caso y por qué se nos había activado de esa manera. Cuando entonces comenzamos el proceso de investigación, esta paciente de 85 años, envejecida, obviamente, adulto mayor, estaba a cargo de sus 2 hijos, ambos adultos mayores igualmente, de 63 y 62 años respectivamente. El problema es que esa paciente está frágil, ya no puede cuidar de sus 2 hijos que para ellos mismos tienen condiciones de salud mental. Así es que en ese sentido, pues ahí fue que se activa todo el protocolo y comenzamos nosotros a investigar. En menos de semana y media nosotros logramos, los 2 hijos no son afiliados nuestros, pero a través de la intervención del Departamento de la Familia, a través de la intervención del Procurador del Envejecido, a través de muchas intervenciones que se hicieron, logramos ubicar uno de los 2 hijos. El otro hijo no lo pudimos ubicar porque todavía estamos esperando un diagnóstico. Así las cosas, fuimos al tribunal nuevamente para entonces demostrar todo lo que habíamos logrado con este caso. E interesantemente, se vio muy claramente en este caso y ejemplificado la fragmentación tan grande que tenemos en nuestro sistema, que sí hay un sistema de salud, no está interconectado, y esto lo voy a decir en inglés para que el doctor lo entienda claramente. And it's not only about not having communication, because here we don't even have availability of those results that probably you guys have available in your systems. We don't even have that here. So, por lo tanto, no es solamente el no tener la información, es que nuestros sistemas no se conectan, nuestros funcionarios no se comunican, y en esa medida el juez obviamente ayer emitió una orden inmediata de que todos los que estábamos allí representando a cada uno de esos pacientes, que no todos eran de Triple S Advantage, solo la paciente de 85 años era de Triple S Advantage, finalmente nos sentáramos, nos comunicáramos y estableciéramos un plan estructurado y un plan organizado para que esta familia, no solamente esa paciente, y ahí llevo a otro nivel esto de patient center ¿verdad? O que sea centrado en una persona, debe ser centrado en la realidad de esa familia en particular. Pues el juez nos ordenó, ustedes se tienen que sentar y ustedes tienen que acordar qué es lo próximo que ustedes van a estar haciendo, no con la paciente, con esta familia en particular, porque no podemos olvidar que esta paciente llevaba 60 y pico de años cuidando a sus 2 hijos. Ahora, al remover a uno de ellos, obviamente nos vamos a encontrar con otras situaciones que no podemos dejar de perder de perspectiva. Así es que básicamente aquí en este sistema y en este ejemplo de este caso, lo que vimos fue primero que el médico primario no evaluaba a esta paciente, tal vez no conocía que era parte de su panel de pacientes, por lo tanto no sabía y no conocía de las necesidades que tenía esta paciente de 85 años. Entendemos que era también deber de nuestra manejadora de casos identificar con un Health Risk Assessment, eso lo buscamos en el sistema. No tenía un Health Risk Assessment porque no la podían contactar, la trataron de contactar varias veces. Tal vez si se hubiese activado trabajo social antes de la orden judicial, hubiésemos podido visitar a esa paciente, identificar esas necesidades y debidamente obviamente entonces llenar las necesidades de la paciente, y no hubiésemos tenido que nosotros entonces pasar a una orden judicial para poder entrar al caso. Así es que vemos la fragmentación, vemos la falta de comunicación y de intervención e interacción entre las diferentes agencias, incluyéndonos a nosotros.
Primero que todo, muchas gracias por la oportunidad de estar acá. I'm going to apologize. I will switch to English to basically get a broad message. So I totally agree, and thank you for that. I think one of the problems that we see here in Puerto Rico, of course, is the fragmentation of the services is very clear. But I think the other big problem is that the healthcare system in Puerto Rico is designed to be reactive, and that is not surprising. I was recently reading, I think about 11 healthcare systems in Latin America are broke. And I think if you look at it, 2 out of 3 healthcare systems globally are broke. And it's not surprising. It's not surprising because I think every single healthcare system in the world is designed to be reactive. It's designed to treat sick people as opposed to being more preventive or optimal treatment and disease management and other types of things. So I don't think the situation in Puerto Rico is unique. I think the solution is going to be unique. I think the situation of Puerto Rico requires a very unique solution accustomed and criollizada for Puerto Rico's needs. But I think the problems are very universal, and it's lack of communication, lack of integration, lack of proper patient care, and I think those are the realities that we live. Again, nothing unique, I believe, nothing unique to Puerto Rico, and it's something that we need to address, and it's a systemic change, a fundamental change that we need to do. And I think when we look about fragmentation and the care delivery systems being fragmented, the solution requires integration, and requires integration of all players in the healthcare system. I was very touched and very moved by Dr. Brenner's talk, because as I was listening to him, his messages were all about that. We're all about integration, and integration both from the providers, the payers, governments, policymakers, payers, health insurance companies, and all of us need to integrate. We in the pharmaceutical industry, and as Dana mentioned, I'm the general manager of a pharmaceutical company, and of course, all of you know we are for-profit organizations. We understood about a decade or 2 decades ago that it's very important that we integrate ourselves as well. And I hope that throughout the panel you will see some of the initiatives that we do to be more patient-centric, because if we don't integrate, we are very well aware that there's going to be healthcare sustainability issues in the island and worldwide. So I think the model, even within pharmaceuticals and even within healthcare delivery, I'm very optimistic. I'm hopeful that we're migrating. I think the speed of migration towards being integrated is something that we need to seriously debate, because I think there's a lot of room for improvement.
Mm-hmm. So you actually gave us this next quote. Caring isn't understanding. You said that to me. So can you explain to everyone, what does patient-centric mean to you at AbbVie? You guys are very early adopters of this. You guys have been doing this for a long time. I think you're probably the very early adopters of doing it. What does patient-centric mean to you, and how do you make sure that as an organization you are understanding patient needs and being able to respond to them and develop insights that drive your business but also provide better outcomes for patients?
Yeah, so I think, saying you're patient-centric and being patient-centric there's a huge, right, canyon in there. And I think if you want to really walk the talk, it requires, a fundamental change. And I think in our company, this almost 10 years ago, I think in 2007, one of our high executives criticized us. He looked within the organization and he heavily criticized us. And the criticism was that we are extremely internally focused. He used to tell us that we're excellent at looking at our bellies. Nos miramos el ombligo. We're very, very good at that. And we're not out there. We don't understand our customers, our stakeholder needs. And he basically threw us out of the office. And he said, go out and start talking to people. And don't come back until you understand very well to the core of the issues that all of your stakeholders, and not just the issues today, but you need to anticipate the issues 5, 10 years from now. Because if we want to be a different company, if we want to integrate, we need to understand our customers, including the patient, most importantly the patient. So we started this transformation in the company. And like anything in change management, it's very slow and there's a lot of resistance. I think Dr. Brenner mentioned it as well. People hated it. But it's that persistency from the senior management that basically told us, go outside and talk. Look outside your desk. Look outside your emails and your own business needs. And we went out there and we basically came out with a lot of methodologies. Innovation was a big part of it. We are big believers in the design thinking part. But I think that the part that made us most patient-centric is we started working with the concept of patient journeys. And this was, I think, the game changer for us. We started looking at the patient, the pilgrimage of the patient, all the way from being a person, as you pointed out, and I think in this graph you see it over there, and understanding that roller coaster of this patient. Looking at every single step, and where are these patients falling out of control? Where are they basically, what are the pitfalls where these patients are actually suffering? And everything that we did in all of our functions in our company, where it's marketing, patient relations, government affairs, even finance, whatever it is, it had to be anchored to the patient journey. So if the solution that was coming to us did not add value to the patient, it's not funded. It's as simple as that. Every single initiative was funded based on the patient journey. Every strategy of the company got anchored to the patient journey. So we identify their moments of meaning. We call them these moments of meaning within the patient journey. These are areas where we see tremendous opportunity to help these patients. And then we took those moments of meaning and we used innovation techniques like design thinking, we used innovation workshops, and then we came out with our brand plans and our strategies and our stakeholder engagement plans and all of that. And based on that is when we started adding value. That was a big, big step. By doing that, by going out and actually talking to our customers, where we thought we knew them, we really thought we knew them, and when we went out there, we found out we knew nothing, basically. And by looking at that, we understand, for example, a very critical part. Our initiative started once, for example, the doctor writes a prescription, right? That's when our marketing teams historically used to go to work, right? Trying to see how we can, maximize that. And then we failed to look at the early parts of the patient journey. Disease awareness, parts where preventive care were important. And we started adapting, and we started putting initiatives that basically helped us understand and helped us add value. Because differentiation is a key thing. We understood, and other companies as well, we are very active on this model in the Pharmaceutical Industry Association, and I think any multinational these days is working with this model. And that's what I was mentioning before. I think a decade or two ago, we all changed our way, our mindset, our way of thinking, because we understood that if we don't work like this, we're not adding value to the system. So I think this is the part that we believe we can be patient-centric. I mean, a lot of the times, we try to be engaged in the community and provide donations and sponsor 5Ks and 10Ks. And yes, that is one way of being patient-centric, but the real difference of being patient-centric is when you use your expertise, when you really use your expertise, and there is a lot of expertise in pharma, in what is called disease management. When we use our expertise to add value to patients, that's when we become patient-centric. And it took us 10 years, and we still have a lot of ways to go.
Mm-hmm. Now, he referenced having to get out of the office, right? Get out of the office, get in front of patients. At Triple S, you've been doing this as well. You've been going out and spending time with patients. How are you putting your people in front of patients, and what kind of value is that bringing back?
Sí, parte de nuestros programas de manejo de casos específicamente también han evolucionado a ese outreach al paciente directamente. Un ejemplo es el programa que mencioné anteriormente, Gerosocial, porque como parte de los requisitos que nosotros tenemos con las agencias reguladoras, obviamente nosotros tenemos que primero desarrollar y evaluar las necesidades específicas de ese paciente en particular. De acuerdo a esa evaluación de necesidades, nosotros desarrollamos y tenemos que desarrollar un programa o un plan de cuidado individualizado. O sea, ahí es que nosotros entonces incluimos el patient-centric, porque tiene que ser de acuerdo a las necesidades de ese paciente en particular. Nosotros realmente no podemos diseñar programas que sean cookie cutters. Tenemos que demostrar que nosotros estamos identificando las necesidades, estamos desarrollando esos planes de cuidado y de acuerdo a esos planes de cuidado, entonces nosotros desarrollamos y establecemos cuál es el plan de seguimiento con ese paciente en particular. Hemos integrado disciplinas tales como psicología, obviamente, trabajo social. Es una de las disciplinas que nosotros tenemos como parte del equipo de trabajo que directamente sirven de enlace no solamente con el paciente, sino también con los médicos primarios, con los médicos especialistas, con todos los proveedores que son parte de ese equipo. Yo creo que parte de la evolución y de esa transformación que nosotros tenemos que llevar a cabo es que nosotros los profesionales de la salud y específicamente obviamente los médicos tenemos que vernos como parte del equipo de trabajo. Solía ser que el médico era el centro de ese equipo de trabajo. Ahora nosotros tenemos que migrar y conocer que ese paciente es el centro, no es el médico, y realmente el médico es parte del equipo de trabajo. Y de esa manera poder diseñar planes que tengan outcomes o que tengan resultados que sean efectivos para ese paciente en particular. Eso es uno de los requisitos que nosotros tenemos que cumplir directamente, obviamente con las agencias reguladoras, y con este programa nosotros hemos logrado identificar situaciones que no necesariamente son situaciones médicas, pero sí son situaciones sociales que inciden en el cuidado médico de ese paciente, y que el médico primario o el médico especialista o los otros profesionales profesionales de la salud que realmente intervienen con este paciente no tienen acceso a esa información. En Triple S nosotros nos hemos dado a la tarea de evaluar no solamente nuestros programas internamente, sino que hemos evaluado nuestras estructuras, de manera que nosotros podamos hacer ese outreach más directo, que podamos tener ese contacto más directo, no solamente con nuestros afiliados y afiliadas, sino también con nuestros proveedores, porque son parte de este modelo y parte de este sistema que queremos emigrar o queremos transformar a uno más centrado en el paciente.
Gracias. I actually have up on the screen what the beginning of a journey map is, and it usually starts out as a messy process, and you see a lot of post-it notes there. And from Felipe, you guys put a lot of effort into this. I guess this doesn't happen overnight, and I would imagine it's more than just clinical data, and like you were saying, it doesn't just start at the moment that there's a prescription. You're looking at people pretty holistically. What goes into you guys at Avi building this up, and then how are you developing it? How are you keeping it human? What are you putting into it? How do you invest in getting this process till you have something that helps you make better decisions?
Yeah, so building a patient journey, because it's the foundation it's the starting point of every single one of our strategies as a brand and as a company. We put a lot of effort in this, and we've gotten better through the years. At the beginning, there was a lot of secondary database coming in, and clinical research and studies and things like that. And then we have evolved. Today, when we build our patient journeys, it's about a 4 to 6 month process by which there's a combination of primary and secondary research. A lot of market research goes in, focus groups, individual interviews, motivational interview goes in to the patients, to the caregivers of those patients, to payers, to physicians. You will see, typically we have 1 season through the year that our teams are in the outreach stage, where they go and they'll talk to many of you about, where do you see your field moving? What are your needs? What keeps you up at night? And just by listening, we understand a lot. We bring all of that knowledge back, and then we start doing brainstorming sessions and war rooms, and then you'll see rooms like that where there's just a lot of ideas coming in until we actually systematically map every single point in the patient. Now it gets complicated because, as you can imagine, here in Puerto Rico, this is a very perfect example, right? A commercial patient, a patient with a private insurance, will have a different journey, even though it's the same disease, as a patient from Medicaid, from Mi Salud. Right? It will be completely different. So we will have to map those and adjust those according. So it gets extremely complex. And of course, we would love to have a patient journey for each patient. And I think I admire a lot the Triple S, individual part, because that's where we aim for. That would be the optimal model, when we can go and look at the pilgrimage of that patient with a name on it, so that we can find the optimal solution for that patient. But obviously we can. We have to try to aggregate things, and we come up with journeys like that. So it's an enormous amount of work, but we believe is the best way to move forward. As opposed to just basically coming out with a strategy that could be global or could be regional, and then going and implementing for a market that it might not even work in a country like Puerto Rico. We believe it's a bottom-up approach, and it starts with this. So it's a lot of work, but very well spent. Resources very well spent.
So you're talking about resources really well spent. I'm sure a lot of people here, when you're talking about it, you think, well, we're treating people better, we're being more empathetic to people. But there's a business outcome to this. How does this help your business? You invest a lot in this, in being patient-centric. Can you give us an example of how this helps you make a better decision?
So one of the things that we learned through these patient journeys is we understood that if all we're going to do is sell pharmacology, we're not going to differentiate ourselves. I think any other pharmaceutical company, all pharmaceutical companies, we sell pharmacology. And when we look at these patient journeys, it is crystal clear that pharmacology is just one part of this equation. Pharmacology alone is not going to get it done. You need patient support services. You need disease awareness. You need, again, integration of other services. You need strategic alliances, partnerships with other agencies, patient associations, payers, programs, disease management programs, hospital programs. You need a lot of things together that the patient is is demanding to give them the optimal care. One example, just to your question, then I think one example is we understood that having a patient support program will make a difference, and we probably invest more in our patient support programs than in our marketing activities, because we understand that when we're selling or we're promoting specialized pharmaceuticals without a targeted, very, very well-designed, comprehensive patient support program, that specialization might not get its maximal potential. So one example is we have a team of nurses, for example, at AbbVie, that go out and basically are very involved in the life. They carry the patient story. I think that was said in the earlier sessions in the morning. No one is really carrying the patient story. Well, these nurses do. These nurses are going to the patients' homes and they're understanding what is going on with their lives. Nothing to do with pharmacology, nothing to do with clinical opinion or medical opinion. It's just what is going on in your life and how can we help you understand, for example, the value of adherence. Because if you understand the value of adherence and you take your medication as your doctor prescribed it, you're going to have a better clinical outcome. That is an important thing. We didn't see that before that. That team of nurses, of course, an investment that we do, and it's free for the patient and free for the healthcare system, but that actually helps the patient a lot. So by doing that, by looking at these journeys, we identify that some of those nurses actually are awareness, are advocate nurses that actually talked about disease awareness. I think a good example of that is we're very involved in the field of dermatology and psoriasis, for example. And many of you that have been close to psoriasis has evolved significantly over the last 5 to 7 years, okay? So before the introduction of biologics, for example, psoriasis was basically treated with topicals. They were not very effective at all. A lot of those patients, and psoriasis is a lifelong chronic disease, right? You're gonna live with psoriasis, there's no cure, you're gonna live for the rest of your life. A lot of those patients that got treated in the 80s or in the 90s, they were topical after topical, cream after cream, and nothing worked. Those patients eventually quit, and they went back home, and they stopped going to the doctor because like nothing worked. And today, you can find many of those patients that have gave up. They have given up, and they're at home basically crying and miserable because of their plaque psoriasis, without ever knowing that 5 or 7 years ago, new medicines came to the market, and these new medicines now can give you clear skin. Now, if we don't get that message out, if we don't do this awareness, and a lot of these nurses are actually going there talking to these patients about options, go back to your doctor. There are options these days. Try again, and a lot of those are getting activated to care again. A lot of those patients are getting activated to care. And it's beautiful to see how those patients are now they're getting married, they're having children, they're having very fruitful lives because of second chances in medicine. This is innovation in my eyes, and I think this is what came out. Without having tools like this, it would have been impossible for us to realize that.
Mm-hmm. Thank you. You've both talked a lot about collaboration, and I know that you talked to me a lot about the need to work with other agencies and nonprofits, and that healthcare is something beyond the healthcare industry. How do you guys at SSS try to keep the patient at the center of every interaction by working with other people?
Sí, como parte de toda esta, ¿verdad? De todos los esfuerzos y los outreach que nosotros llevamos a cabo, obviamente no todo puede ser manejado a través del plan médico, o no todo está cubierto y por lo tanto tenemos que hacer muchas intervenciones con agencias gubernamentales, agencias non-for-profit y otras agencias que tenemos disponibles ¿verdad? En Puerto Rico. No obstante, conocemos de los retos que tenemos con estas agencias también y en ese sentido han sido varios los pacientes que se nos han quedado tal vez sin los servicios completos y sin ese outreach a esas agencias por la misma situación en la que estamos viviendo. Así es que yo entiendo que no es solamente el tener todos estos recursos, es tener los recursos apropiados, porque podemos tener muchísimas enfermeras en el field, pero si realmente no es la enfermera apropiada, que tenga el conocimiento, que tenga los contactos adecuados para poder ayudar a ese afiliado, a ese paciente en particular, pues no vamos a lograr, primero, identificar lo que queremos identificar y segundo, entonces poder ayudar a ese paciente. Así es que es más allá de nosotros tener los recursos, es tener los recursos apropiados para trabajar con esta población en particular. Porque muchas veces durante el proceso de reclutamiento, como tenemos retos también en ese proceso de reclutamiento, no necesariamente llegamos a reclutar a ese recurso que va a tener ese compromiso y ese seguimiento con el paciente en particular. Así es que no es nada más nosotros tener los recursos ahí destacados, es que esos recursos, como decimos, ¿verdad?, den la milla extra y que no se limiten a sus funciones o no se limiten a lo que es a sus responsabilidades, sino que vayan un poco más allá, porque nos toma mucha innovación, nos toma mucha creatividad nosotros poder llegar a resolver o a por lo menos crear esa sustentabilidad que nosotros necesitamos para poder mantener el cuidado de ese paciente de manera óptima. Así es que yo lo veo más allá de tener recursos, es tener los recursos adecuados. A veces con un recurso tú puedes lograr más que con 5 recursos, porque todo depende del compromiso que tenga ese recurso en particular. Así es que es educar a esos recursos, educar a esa fuerza que va a estar ayudándote en ese proceso, pero es seleccionar a los recursos adecuados que van a trabajar con esa población que has identificado.
Porter says that by focusing on cost containment, that payer, provider, pharma, policy, all tend to try to defend their own little area. But by putting the patient at the center, it gives us kind of like a common language, and it provides kind of a north for the entire industry, and that there's benefits to that. If you focus on the patient, you actually do reduce the cost, but it takes kind of a shift. How do you see that collaboration happening? What are the barriers to that kind of collaboration happening? But how does being patient-centric get an entire industry to start working in unison?
Yeah, so I think one of the changes that we did when we started really being serious about being patient-centric is starting to understand, for example, ideologies like Dr. Porter in Harvard. The concept of, he redefines the concept of value, right? As you pointed out, and he says today's medicine is basically is a cost-driven healthcare system. And as long as we continue to focus on cost, we're just not going to go anywhere. It needs to be value-based, and that's why you put the equation. He redefines value, right? And value is a component of quality of care, right? I think Dr. Brenner mentioned, is the right patient with the right treatment at the right time. That's quality of care. If we continue to look at cost, we're not going to get anywhere. So when we look at quality of care, it's all about patient outcomes, and I think that's what a lot of the systems are trying to migrate towards. Basically rewarding based on patient outcomes. Patient outcomes is important. It took us a while for us to understand that. It took us a while for us to understand that if we really invest in education, in proper education, and we basically help our stakeholders out there, whether it's physicians or whether it's managed care organizations, drive, for example, guidelines or try to comply with guidelines for therapeutic use, we understood that the patient outcomes will get better. That part was clear. But when we started looking at these adherence programs and these patient support programs, and we started actually looking at the patient outcomes getting better, we actually saw a tremendous push in both sustainability of healthcare systems, right? So that was very important. I think there's a lot of controversy whether, Dr. Porter's ideologies are real or not, or work or not. But the reality is that when you look at closed systems, when you look at value-based healthcare in patient outcomes, sustainability is achieved. You reduce costs. If you deal with those healthcare inefficiencies, you can actually maintain your budget, treat more patients, provide better quality of care, better patient outcomes, and at the end, it's a win-win situation for everyone. So I think that's the big part. Obstacles, there's many obstacles. It's not an easy model to implement, and I think it requires everybody getting their bias out of the way, making sure that we all understand where we need to go, and if we truly put the patient in the middle, I think we can achieve that.
Yo creo que adicional a lo que ha mencionado, básicamente el sistema de salud se va y se está moviendo a mecanismos alternos de el valor de ese dólar que se está invirtiendo. Ya no hablamos de gasto, ¿verdad? Ya hablamos de inversión en calidad. Calidad no es nada nuevo. Calidad lo llevamos hablando por muchos años. Y Triple S Salud ha sido una compañía que siempre ha estado a la vanguardia de lo que ha sido calidad de servicios de salud. Y siempre hemos estado educando a los médicos, educando a los proveedores en relación a cómo ofrecer unos servicios de calidad, cómo identificar a los pacientes que necesitan cuidado, cómo identificar, cómo llevar a cabo esa prevención y esa promoción en salud. Hemos sido líderes en la industria en ese sentido. Ahora, obviamente con las nuevas regulaciones, Medicare está poniendo un peso adicional. Ya ahora no es nada más el rescore, ahora tenemos que demostrar que sí se están cerrando esos gaps en cuidado, que sí se está identificando esa población específicamente que no cumple con esos indicadores de calidad. Ahora es diferente sentarnos en un salón de conferencias a discutir sobre el medical cost o el medical expenditure, cuando nosotros podemos decir, no, esto va con las estrellas, así es que ahora todo el mundo quiere estar alineado con las estrellas y quiere estar alineado con los indicadores de calidad. Y ahora sí podemos justificar que este programa tal vez tiene un costo, pero a largo plazo va a tener un impacto positivo en la calidad de servicios de esa población en particular. Así es que yo creo que ese paradigma ha ido cambiando en los últimos años, precisamente porque se le ha puesto un peso financiero a lo que es quality of care. Yo llevo 15 años en esta industria, comencé precisamente en el departamento de calidad como directora médico de calidad y realmente era bien difícil hacer entender que teníamos que invertir en ese momento en tener unos sistemas de informática que nos identificaran cuál es la población que no me está cumpliendo con esos indicadores específicos de calidad, que diseñáramos programas y que diseñáramos modelos de compensación para nuestros proveedores y para nuestros PCPs que estuviesen más alineados con la calidad, en lugar de estar alineados con el costo o con la inversión que se estaba haciendo con esos afiliados en particular. No obstante, ahora es mucho más fácil porque obviamente tiene el peso financiero desde el punto de vista de Medicare, que si no cumplimos primero, pues no vamos a tener la certificación, por lo tanto es un peso adicional y eso nos ayuda desde el punto de vista clínico a nosotros alinear los beneficios, a que esos beneficios que están atados específicamente a los indicadores de calidad no tengan copagos, que podamos limitar esos copagos y ayuda también a que esos modelos de compensación que estamos diseñando para nuestros PCPs y para nuestros proveedores estén alineados con los benchmarks o con los indicadores de calidad y más bien con los resultados, no solamente con los indicadores, que cumplan con los indicadores, sino con los resultados, porque ya sabemos que ya no es nada más hacerle la hemoglobina glucosilada a los pacientes diabéticos, es que esa población diabética esté en control, o sea que ya estamos pasando a otro nivel. Y esto ayuda a que esos indicadores nosotros vayamos viendo esos resultados moviéndose. Hace casi 4 o 5 años atrás podíamos ver que el cernimiento para cáncer colorectal en la población de Medicare Advantage en Puerto Rico podía estar por debajo de un 30%. Ahora podemos ver que con todas estas iniciativas que hemos llevado a cabo, estamos por encima de un 70%. Y eso es ¿verdad? Un case study donde nosotros hemos podido demostrar que educando, modificando los modelos de compensación, modificando los beneficios, podemos mover esos indicadores adecuadamente.
So if we can get organizations to be patient-centric, and that involves learning all kind of new rules and kind of shifting the mindset within an organization, which, as you said, it takes time, it's very hard to do. But if that gives us all this central point, focusing on the patient, and we can get people to collaborate, that should lead to sustainability. And I was hoping you would speak a little bit more about Project Susie from PIA and how that leads us to sustainability. How does that collaboration look?
Yeah, so here's where I think I need to sort of take my hat from AbbVie and put my hat as a member of the Pharmaceutical Industry Association here in Puerto Rico, where it's basically a conglomerate of all the multinational companies that are research-based companies here. And as I said before multiple times, we understood that we need to be part of the solution. So all of us, we're sitting around a room thinking, how can we help, right? There's healthcare crisis in Puerto Rico. How can we help as an industry, right? Of course, we are very limited in the way that we can access patients. We are not healthcare providers, right? We are a pharmaceutical industry, right? But we understand the problem. As I said before, there's a lot of expertise in our industry, and when we look at today, for example, if you look at the left part of the slide, you see if you look at any type of disease where there has a particular prevalence, right? There's, I don't know, 1 million people with this disease in Puerto Rico. Only a subset of those patients are actually on care. And then you can question those that are on care, whether they have the right treatment and they're being treated at the right time, right? But some of them are on care. Inevitably, and this is being validated over and over, patients that are on care are patients that are less expensive. Why? Because they're on care, right? Patients that are not being treated properly, the right patient at the right time with the right treatment, those patients are the ones that perhaps will end up as superutilizers, right? Those patients are the ones that are going in and out emergency rooms. If you don't have proper access to care, those patients end up costing the system a lot of money, right? So the name of the game is simple. Let's get more patients on care, but the right care, right? Not misdiagnosis, not underdiagnosis, the right care. So if we don't do that, then we're going to end up in healthcare crisis, and that's where we are today, right? So as I said before, I think 11 healthcare systems in Latin America are broke, and the way that being bankrupt is defined is when the cost of healthcare exceeds your budget, right? And they don't grow at the same level, right? I mean, healthcare costs are growing much faster than government budgets, and that's very simple. When you exceed that budget and you start borrowing money, that's when you enter into crisis. So we are very aware that the chance of increasing the budget is not an option. So we need to reduce the healthcare cost. And the way that we do that, the way that we break this trend is by integrating, by providing different models. Like, for example, what Dr. Brennan was talking about, integrated, comprehensive, patient-centric models that we can do that. Now, the problem is that is a long-term solution. That's not a short-term solution. And that's the issue that we face typically, because when we look at governments where a lot of the healthcare budget comes from a centralized unit, for example, the government, then the term of the government decision-making gets into the equation. And that could be an issue, right? So when we look at short-term things, yes, something like, for example, the superutilizers program is a fantastic thing. But in reality, an optimal scenario, we shouldn't be dealing with superutilizers, right? That's a consequence of having a system that is inefficient. So we need to change the inefficiencies. And I think that's what Project SUSI is. In PIA, we started this initiative a couple of months ago, and Project SUSI is basically Sustainability Strategic Initiative, which is basically working with payers, working with the government, and working with providers, integrating ourselves to come up with pilots, specific pilots in high prevalent diseases, such as diabetes, such as asthma, such as hypertension, where we can put disease management pilots to try to get those patients to care in a better way, optimal way, so that those patients don't go out of control. Because if they go out of control, they end up costing the government a lot of money. So that's what the project is. We just started, and we have great partnerships already going on. AAA is one of those companies that is very engaged on this program, and we hope to start those pilots fairly soon so that we can start showing some evidence and some data that by doing this team care, this comprehensive, cross-functional, multifunctional care, that we can actually achieve better cost efficiencies.
Well, with that, I leave you all with a quote, because you've heard about patient-centric, you heard about the need to collaborate, you all know that there's a crisis in Puerto Rico over healthcare. So I leave you with this quote. This is one of my favorite quotes. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has. From Margaret Mead. And if you look about the people around the room, this is, it's a moderate-sized group, a representation from your industry. If we plan to deal with the healthcare crisis in Puerto Rico, it'll take thought leaders like these two people here, but it'll also take all of you deciding to collaborate, work together, work towards sustainability, and disrupt healthcare. Thank you so much.
Thank you very much. Gracias, Dana.